there, and a very warm welcome to you. Thanks for joining us again for one of our very intriguing online interviews with some of our most esteemed consultants in the UK. And today I'm delighted to say we're joined by revered interventional radiologist Professor Mark Little and consultant urologists Mr. Sunil Kumar and Mr. Chris Blick. And the three consultants are part of the highly esteemed the Urology Partnership. And today, delighted to say we're going to be, talking all about benign prostatic enlargement. So the first question I might pose to all three of you guys, what symptoms may men have if they have an enlarged prostate?
Shall I start off?
Yeah.
Well, men with enlarged prostates may often notice that their urinary flow starts to deteriorate. It can also mean, as a result of that, they're going to the toilet more frequently than they used to, and perhaps also getting up at night. These symptoms can increase this condition can increase their risk of urinary tract infections as well. And as a result of obstruction, some patients also do develop some urgency to pass urine and some dribbling towards the end of passing urine. The flow tends to slow down as men get older, and hesitancy is one of the main symptoms that they may notice initially. So when we assess patients with a benign prostatic enlargement, the questionnaire looking at these symptoms is one of the first things that we consider.
Fantastic. And I suppose if they notice those symptoms, on a frequent basis, you would encourage them to get checked out maybe as quickly as possible.
Yes, I would say so. I think if the symptoms are affecting their quality of life and stopping them from doing things which they would normally do, then they should seek help pretty soon. I think if they're getting infections or having wet episodes or leaking urine at night, they'll have to seek help reasonably urgently.
Fantastic. Thank you very, very much, doctors, for that very insightful response. Leading us nicely on to the second question. When should a man seek help from his GP or urologist? Is there a certain age bracket?
Urinary symptoms can affect men of all ages. Symptoms related to benign prostatic enlargement tend to become more prevalent after the age of 50. But as Mr. Kumar said, I think if any patients are noticing that their urinary symptoms are affecting the way they live their life day to day, they're struggling to sleep as a result of that, or they're suffering from urinary tract infections or have any concerns with blood in the urine or leakage of urine, certainly they should try and seek help sooner rather than later.
I think one of the issues we have is that a lot of men suffer in silence. So by the time they come to clinic, they've often had many years of these symptoms creeping up. So it's good for them to present as early as they can, really.
And it's often a very gradual change, and so people may not notice it. It's not sort of one morning you wake up and suddenly that you're really struggling to pass urine. It's something that creeps up on patients. So it is often something somebody else may tell a patient. You know, we've noticed you're spending a lot of time in the toilet, or you're getting up all night. Wives or partners may notice that, and I think taking on information from other sources as well is useful.
Absolutely, it's definitely something that they notice over a long period of time, or their partners, like you say, Mr. Blick, and I suppose it's very, very encouraging, I suppose, with the treatment options now available. The advancements are numerous now. How would you maybe compare the advancements in terms of treatments these days?
I think the treatments have certainly mushroomed recently. There are a lot of options available, some very minimally invasive, but patients would need a full assessment, and because one treatment doesn't fit all prostates, and that assessment is crucial to then deciding what treatment would be appropriate for each patient. So that is important, I think.
Fantastic.
Yeah, I think one of the advantages as well working within the partnership is we have the ability to provide a whole raft of treatments which we can tailor towards different patients. And A lot of that is to do with the workup, as Mr. Kumar says. So prostate volume is obviously an important marker as to which treatment we will decide to use. And also things such as comorbidities and other medical issues that the patients may have will focus us in terms of choosing one particular treatment over another.
Absolutely. Fantastic insights again, doctors. Really, really helpful for patients who are watching for sure. And then, well, the third question, does having a large prostate necessarily mean men are more likely to get prostate cancer? Or is there a definite link there?
I think having a large prostate is not a definite link to having cancer. A large prostate would certainly have an impact on or cause obstruction to the outflow of the bladder. But part of the investigations would include or exclude the presence of prostate cancer, because we can always do scans and a PSA test to make sure that the prostate enlargement is indeed benign.
I mean, it's relatively uncommon for prostate cancer to present with symptoms. In the majority of patients, it's picked up incidentally, and actually a lot of urinary symptoms are related to a benign enlarged prostate rather than underlying prostate cancer. But as Mr. Kumar said, often patients will have an MRI scan as part of their workup, and also a PSA blood test. And generally speaking, patients who are concerned about prostate cancer, we look at risk factors, ethnicity, family history to determine when and what age they should start considering these blood tests. And that's something that we discuss with patients during their initial assessment.
Fantastic. And you mentioned there, Mr. Kumar, Mr. Blick, PSA tests and MRI scans. And would there be any other specific scans or tests required?
So in terms of the workup for men with benign prostate enlargement, the three imaging tests that many will undergo are an ultrasound, which is a very simple test whereby the patient comes in, lies on a couch. We use some jelly and a probe to visualize inside the patient. And what we're looking for, we're looking at the kidneys first and foremost, because men who have benign enlargement can often get restriction of urinary flow. The bladder enlarges and you get back pressure onto the kidneys. So what we try to exclude is to make sure the kidneys aren't dilated, a condition called hydronephrosis, which can affect kidney function. So we want to visualize the kidneys using ultrasound to exclude that. We also want to look at the bladder, and that's twofold. Firstly, to look at whether there's any outpouchings of the bladder that can be indicative of chronic outflow obstruction, but also we'll use it in combination with other tests such as flow rate tests to see how well the patient is emptying their bladder. So we look at how much volume is left after a patient has voided. And then finally, we use the ultrasound to actually look at the prostate and assess the volume. It's a very quick, efficient way to do that, and we can do that in clinic, again, which helps us stratify which is the best, or which are the best treatments to offer patients. So ultrasound is a very quick, useful tool that we'll use. And then, as Mr. Kumar has already mentioned, MRI is used to rule out prostate cancer. That's the best imaging tool we have at the present time to rule out cancer, and it's used a great deal on men who go to their GPs or see us in clinic with raised PSA blood tests as an accurate way to try and stratify the likelihood that the gland contains cancer, which may then initiate a biopsy.
Fantastic. And you mentioned there a biopsy at the end, and in certain situations, the biopsy will be required. Will that be quite indicative of prostate cancer if it has to go to a biopsy, or not necessarily?
Certainly, the biopsy is the gold standard diagnostic test for prostate cancer. It's not something we would routinely do as part of workup for benign prostatic enlargement, but it'd be very much guided by the results of both the PSA blood test, the examination of the prostate itself during the clinic appointment, and also potentially an MRI scan, which may lead from that.
Fantastic. Really, really insightful again, guys. And on to the next question then. How do you assess a man with urinary symptoms then?
I think as Mr. Blick and Professor Little were saying before, Patients would fill in a questionnaire, which would give us an indicative idea of how symptomatic they are, their quality of life, and then we would do a urine check, dip the urine to make sure there isn't an infection or the presence of blood in the urine. And then we would obviously talk to them and take a full history, assess them from that point of view. From a test point of view, they do a flow test where they pass their urine into a machine, which would give us a graph, which would be give us an idea of whether there is ongoing obstruction. And as Professor Little was saying, then we would do a bladder scan to see how well they're emptying their bladder. On top of that, we do some blood tests to check the kidney functions are okay, if they haven't had that done already, and potentially a PSA, which would kind of then give us an idea of whether they need further testing, such as an MRI, before we decide on treatment.
Fantastic, Mr. Kumar. Absolutely, it's very encouraging, like you said, about the treatment and the prognosis. Then I suppose it's definitely, there's a better outlook than maybe 10 or 15 years ago if somebody is diagnosed with benign prostatic enlargement.
I think there are a lot more options now, and we're taking more into consideration functional outcomes. And what I mean by that is patient preference. How important are things like ejaculatory function, minimizing the risk of potential complications such as incontinence or erectile dysfunction. We have to bear all these things in mind, and I think that's what the newer options are providing us with. So technology will continue to advance, and certainly it's an area of significant growth at the moment.
Absolutely. And well, moving then to the next question for you three. I suppose, what does having an ultrasound or MRI scan involve? Will it take long for patients, or is it maybe potentially uncomfortable?
So ultrasound, as I said, is a very quick diagnostic test. It's probably most commonly familiar to patients with regards to pregnancy. Obviously, women who are pregnant have ultrasounds to check babies. Within men who come with benign prostate enlargement, as I mentioned, we are looking at the kidneys, bladder and prostate, and the examination takes typically around 5 minutes to do. It's not painful, it's very quick. MRI is a bit more involved, so for that they'll go to a specialist MRI unit where the patient will lie in a tube. So it's important that we counsel them about that, because some patients will be claustrophobic with MRI, so there are some things that we can do to try and alleviate. That's often just talking and explaining through the procedure is enough, so that patients have that in mind when they attend for their appointments. The MRI examination itself takes around 45 minutes, and as the name suggests, it uses strong magnets. So there are some circumstances where patients may not be able to undergo an MRI scan, such as if they've got magnetic material in the body, such as a pacemaker or clips in the brain. So these are things that are screened for when they go to their appointments. But both tests are very commonly available and don't hurt, so pain-free, and provide us with a great deal of information.
Fantastic. Very reassuring, Professor Little, for the patients to hear that for sure. Maybe somebody who's undergoing their first MRI or ultrasound scan, that's very reassuring. So thank you for that. That's excellent. And then, well, the next question. Are there any lifestyle modifications men can make to reduce their risk of developing urinary symptoms? Or for those who already have had them, what can they do to maybe get rid of them or prevent them from recurring?
I think lifestyle modifications is probably the first thing we would advise most patients to do. And there is reasonable evidence to say that 15% would have a symptomatic improvement if they modify the lifestyle. So going into the fluid history and finding out to a certain extent what type of fluids they are drinking on a regular basis, and also trying to do a frequency volume chart which documents the intake and output and what kind of volumes they're passing, would give us an idea. And certainly advising them on that does show a benefit.
There are certain things, particularly caffeine, alcohol, to a certain degree, things like spicy foods and fizzy drinks can all drive bladder symptoms, and people are sometimes unaware that they're drinking too much. The average person doesn't really need to drink much more than 2 to 2.5 liters over a 24-hour period, and so it's really important to understand what people are doing at that point in time to see if we can just perhaps avoid the need for tablets, medication, or intervention.
Absolutely, Mr. Blick. And you touched on medications then, and going into medications and procedures then, firstly, touching on medications, what medications would be most recommended for patients with prostate cancer or benign prostatic enlargement?
For benign prostatic enlargement and symptoms secondary to that, we would advise once they've had their assessments, and we obviously need to make sure they're medically fit to have these medications, because they do have some side effects. And we would advise alpha blockers such as tamsulosin and potentially other drugs which are finasteride or dutasteride for the treatment. It depends again on the assessment and how symptomatic they are. And if they do go on medical treatment, we potentially reassess them in about 3 months or so to see how they've fared with the medications.
Excellent. And you mentioned there a follow-up in 3 months after they start taking the medication. Is it normal for patients to react well, or are there some certain risk factors or side effects?
Yes, with all drugs, there are side effects, and some patients decide that they just don't want to take medication longer term. And so that's when we start to discuss the other options for them. Alpha blockers are very well tolerated in general, but they can cause some changes with ejaculation, something called retrograde ejaculation. They can also drop blood pressure slightly. The gains or benefits of medication are limited to a certain degree. So patients who have more severe symptoms may find that actually it doesn't get them to a point where symptoms are well managed. There is some evidence more recently that another form of medication, something a PDE5 inhibitor, also helps improve flow in combination with other treatments. So there are a few options available. And as mentioned before, it really does depend on the severity of the symptoms and the outcome of the investigations as to whether this is an appropriate step for these patients.
Absolutely. And then heading into the procedures available then, what procedures are mainly available to treat an enlarged prostate? And how do you decide which patient should have which procedures?
Should let you talk about PAE?
Yeah, so as I say, we're lucky here because we provide pretty much the full gamut of procedures. I think one over the years, the biggest stratifier that we have found useful is volume. So for men with large glands, I think the options are probably amongst HOLEP, which is what Mr. Kumar is a specialist in, or prostate artery embolization, which is the procedure that I've pioneered over the years. So gland volumes certainly over 150 mils. That's a sort of treatment strategy that we would be thinking of. Certainly less than that, you're into other minimally invasive treatments such as Resume, Urolift, or aquablation, which is a newer treatment. But I think it's useful to have sort of a mini MDT approach to all of these patients so that we can provide the very best and give them all of the options. And there are pros and cons to each. I suppose it'd be useful to talk through that in terms of the success of one treatment over another, but also the risk profiles. So should we start off then by sort of think about the smaller glands?
Yeah, I mean, broadly speaking, it's much more patient focused now than it had been previously. And to simplify it, really, I think there are two groups of treatments. There are the sort of almost ambulatory treatments, the quicker treatments, which don't take very long. Patients can have it done as a day case. They can even have these done under local anaesthetic in an outpatient setting. These are Urolift and Resume, essentially. Urolift is where we put small implants into the prostate, which open it up and improve flow. Whereas resume is a procedure where steam's injected into the prostate and the prostate shrinks soon after that. Both these procedures have been around for about 6 or 7 years now. And the key indicators really are patients off medication happy with their results? What are the reoperation rates? And what are the potential complications? These two procedures really do enable patients to preserve function. So they have very low risks of ejaculatory dysfunction, incontinence, and erectile dysfunction, because you're not really using electricity or heat energy apart. I said steam before, but it's a slightly different type of energy to some of the other procedures used. So from a functional point of view, the outcomes are very good from these procedures, but they don't provide quite the improvement in flow that some of the more definitive operations may do. So when we look at reoperation rates, that's looking at 5 years down the line, what percentage of patients will need either to go back on tablets, have another operation. I mean, fortunately, if you've had a resume or a urolift, it doesn't mean you can't have another operation done sometime in the future. But we look at data, we're looking around sort of 10 to 15% of patients who have urolift will need further procedure, at 4 to 5 years afterwards. Resume tends to have a slightly lower reoperation rate, which is more sort of 4 to 5%. So it's all part of the counselling process for patients to understand what their priorities are. And if they do want something which is less invasive with lower side effect and accept that the success rate is slightly lower, then some of these ambulatory procedures are perfect for those patients. If you need something more definitive, it's probably best I hand over to Mr. Kumar now, as he's a specialist in HOLEP. And then we can come back and talk about some of the options again in a minute. But that's the second category of procedures, in my opinion, of how to manage enlarged prostates.
Thanks, Chris. I think the HOLEP has been there for over 20 years, and there is enough evidence to suggest that in terms of reoperation rates, the 10-year data would suggest the reoperation rate is in the region of 1 to 2%, which I think no other available procedure at this point in time can give you that kind of figure. So if patients have got a big prostate and are not bothered about some of the functional effects that you get, which Mr. Blick was talking about, like retrograde ejaculation or a small risk of possible erectile dysfunction, and they're looking for a longer term solution to the problem, then HOLEP would be the way to go. But some of the minimally invasive procedures, we don't get any pathology back. But with the HOLEP, the tissue is removed, and I would say potentially about 80 to 90% of the prostate is actually removed. So the patient will have very minimal residual prostatic tissue left. And all of that tissue would go to the lab and we'll get a pathology result. So there are pros and cons to everything. And if patients are looking for a long-term result, then maybe HOLEP is the way to go. But then we go into other procedures as well. There is the aquablation, which Professor Little was mentioning, and then the embolization, which I think for really big prostates is a very useful technique because it does shrink the prostate down. And if they then need something further, we can always offer something for their symptoms if it doesn't settle things down for them.
Excellent, really insightful. The three of you guys, absolutely fantastic. Professor Mark Little and Mr. Sunil Kumar and Mr. Chris Blick, really insightful discussion on prostate cancer, the available treatments available now, much more modern perhaps than previous years. And is there anything else any of you guys would like to discuss or mention before we finish today's discussion?
I think a few things which we haven't really touched on is the traditional TURP, which is still offered by everyone, including us. And TURP has withstood the test of time and is a reasonably good operation, but the size of the gland should define that. And maybe with time, the number of TURPs that are being performed would diminish. There are other lasers that are available, which can, and people do use on the prostate, the green light, which is used quite a lot, which is a vaporization technique. And then there's the thulium laser, which can be used to either vaporize or enucleate. So there are other techniques. And if the gland is really enormous, then we'll have to consider an open procedure, which is rarely done these days. And we would offer a robotic simple prostatectomy where the prostate is removed using a robot, but not in its entirety.
Fantastic. And you mentioned there, Mr. Kumar, absolutely, about the removal of the prostate. Is it common to have the prostate removed entirely?
That's more common in the setting of prostate cancer than it is for an enlarged prostate, certainly in the UK. And because we have these less invasive options, such as HOLAP, which can tackle prostates which are of significant size, and PAE, which can reduce the very big prostate. So we would, I'd consider removal of the entire prostate something which is performed in a very small percentage of patients.
Fantastic. Well, Professor Mark Little, Mr. Sunil Kumar, Mr. Chris Blick, many thanks to all three of you for today's very insightful discussion. And if any viewer or listener is watching or listening and wants to find out more information about Professor Little, Mr. Kumar, and Mr. Blick, you can head on over to their Top Doctors profiles on www.topdoctors.co.uk. And well, for now, thank you very much, gentlemen.
Okay.
Thank you.
Thanks very much.
Thank you.